Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary Open Your Eyes on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. And be sure to share your thoughts by emailing me at drkerrygelb@gmail.com or visit my website, drkerrygelb.com. Presbyopia is age-related loss of near vision that no one escapes. The over 40-year-old loss of near vision has traditionally been treated with readers or bifocal and affects about 40% of the U.S. population. Researchers for years have tried to find a non-spectacle option for treating this debilitating disorder. Today's guest, Harvard-trained ophthalmologist Dr. Marc Odrich, and his research team may have found that answer. Dr. Marc Odrich is the Chief Medical Officer at LENZ Therapeutics and TearSolutions, Inc. He is also an Associate Professor of Ophthalmology at the University of Virginia, where he practices and teaches clinical ophthalmology, specializing in refractive surgery and ocular surface disease. Dr. Odrich, thank you for joining me today on the Open Your Eyes podcast with Dr. Kerry Gelb.
Kerry, thank you. And please, Mark, it's my first name, and feel free. Dr. Odrich is my father. So we're going to go with Mark.
Your father was a doctor also, I see.
My father was a periodontist in New York City. So when people say Dr. Odrich, I see my dad, who is still around, 94 years old, and still doing stuff in New York. God bless him. So, but nice to see you, and thank you for having me on the podcast today. I really appreciate it.
So, Mark, I've been a practicing optometrist for many years, and when people get close to 40, a little bit over 40, and I have to tell them they need bifocals or reading glasses or half eyes with that string, I've had patients actually cry in the chair. And, and we really have never had a good option other than multifocals, bifocals, progressives. Now they're contact lenses, but you found an interest here. Why did you get interested in presbyopia?
So it's great question. As you know, and some of the reviewers may know, I started off with the excimer laser, and I was working as the chief medical officer for Visx. And a significant part of the population, patients in the 38 to 45-year-old range, were very excited about potentially losing their distance glasses, but we didn't have a great answer at the time for the early presbyope, and certainly didn't have much of an answer for the presbyope in their 50s and 60s. But it was very clear to me that presbyopia was still an imperfectly fixed problem.
If you could tell us, I talked a little bit about it in my opening, what is presbyopia and what is the epidemiology of presbyopia in the United States and worldwide?
So I think really the way to think of presbyopia is a lens-induced hardening. So the lens hardens as we get older, and the ciliary muscle, which has the zonular attachments and causes a change in shape as they constrict or relax, is now no longer as effective in this change of shape of the lens because it's no longer a plastic structure. It becomes very hard. And that hardening of the lens precipitates this inability to increase your depth of focus in a meaningful way. You don't really get the focus that you had at age 20. And that is the broad answer to what presbyopia is. Presby meaning elder, opia is a vision. So you're looking at what we call elder vision, which is a hardening, a natural hardening of the lens. Interestingly, attempts have been made at trying to keep the lens softer. That's kind of a novel idea that hasn't really borne much fruit. And the other answer, of course, is to just get rid of the lens, even if it's not cataractus, and hopefully put in something that has the ability to offer different areas of focus. So those are all strategies. There have been other strategies that have been used to try and assist in providing that depth of focus that is lost by this natural aging, hardening of the lens. And they're interesting because they're kind of all modeled after this pinhole pupil, the camera inlay being one of them, which was really an interesting thought of putting an inlay into the cornea that had a 3.8 millimeter piece of plastic and had a central opening of approximately 1.6 millimeters. And that would allow this pinhole activity, which increases the depth of focus, as a strategy to get around the hardening of the lens. That camera inlay was something that was used up into the 22-23 timeframe when I think it was no longer offered. Having said that, the demographics are impressive. I mean, you alluded to it and said it very distinctly. It's anybody in that 45 to 70-year-old patient has really demonstrated that they're starting, and it continues right up into their early 60s, late 50s, where their hardening is really so complete that they don't have the ability to focus, and it just diminishes over time. When you talk to presbyopes, they don't think it's gradual. They're very specific in telling us that it's almost in a stepwise progression. And I've heard that so many times by so many thoughtful people that I have to believe that it's true, and that there seems to be this kind of quantum little step leap that happens every couple of years and makes them increasingly aware of how poor their near vision has become. And so when you ask about the demographics, it's about 128 million US folks who have this, and that's, remembering we're somewhere at 330 million plus, it's a significant part of our population, and worldwide it's in the billions. And again, I'm not even willing to guess anymore what the billion number is. It's a significant part of the world population, and as I said, the estimate is right now 128 million folks in the US. So anybody over the age of 45 is likely to start experiencing this, and it starts to really become noticeable in that late 40s, and by 50 to 60, 55 to 60, everybody is going to be telling you, oh boy, I can't do something, computer, reading, simple tasks.
And when you talk about the lens in the eye, the lens is in the eye for those non-doctors in the audience. That's something that's in the eye that actually focuses light. So we have to discuss presbyopia and accommodation. So tell us what accommodation is, and as we get older, the loss of accommodation and becoming presbyopic.
So when we talk about accommodation, we have a metric. We use something called diopters, and the diopters are the way we measure this ability to focus. And it is this dioptric measurement, and that's where you get what we call the ad on the reading glasses or your no-line bifocals, is really based on this ability to focus in. And the diopters of accommodation are the kind of the focus that the eye is able to provide away from its natural refractive state. So when you think of an eyeball can be perfectly round, it could be short, kind of like a squished grapefruit, or it could be like an oval, like an egg. And the squished grapefruit would be much more like a hyperope, and the egg would be the myope with the long distance. And you and I would need a pair of glasses for each of those to see a distance. And then accommodation would be what our lens, ciliary muscle, zonular apparatus, and those are three big words, but they basically are the focusing part of the eye. What those things offer is the ability to now say, okay, this eye, which maybe was an egg, so it's nearsighted, is now in focus at distance. And now we need to be able to bring that in and allow the eye to look at near. And that is the accommodative part of the ocular system. And that accommodation is a number that decreases really starting at the late 30s, early 40s, and becomes noticeable at 45 for almost everybody, and then becomes almost non-existent, meaning there's very little focus, if any, by the mid-50s. So accommodation is really the ability to pull into focus a distant object that has been made in focus by your glasses. It's a fine-tuning, and I think that's the best way to think of accommodation. And in fact, that's what this hardening of the lens prevents. That's where it all becomes a problem, is that lens is no longer able to provide the fine focus.
So you've been studying different types of medications that could be used. What are the different types of medications or mechanisms of action that could be used to help people to be able to read as they get over 40, what we call presbyopia? You mentioned a little bit about lens softening that really didn't pan out very well using lipoic acid. So
right.
What are some other ways that you've looked at as a scientist and clinical trials, some other mechanisms of action, mechanisms to make a person over 40 to 70, 75 to be able to read up close?
Sure. So there are really several ways you could do this. One of which I alluded to early on, which is to remember that the human system for the most part is binocular. And that means you have a right eye and a left eye, hopefully, and they're both working. And your brain takes that image and puts that image together. And it's a really neat feature because it's a neural processing issue. That's what monovision leverages. That was the first thing we chatted about. And monovision really is allowing one eye to have some really non-distinct amount of near vision that is right for the person, and allow the other eye to see more clearly at distance. And then for the brain to say, okay, I'm going to take the sharper image of these and I'm going to literally concentrate on that. And it seems to work for a lot of people, although it's very labor intensive. It's not a perfect solution because, as I mentioned, there are still things that you might not be able to do well with monovision, one of which might be driving at night, where your non-dominant eye is still nearsighted and you get glare and halo and other side effects from that. So that's number one. So monovision is a strategy. Another strategy is at the corneal plane, and that was what I described of making something called a multifocal, having different curvatures and different powers carved into the cornea. And this is a surgical way of doing it, but there's also the contact lens multifocal, again, sitting on the cornea. So one is carved into the cornea, that would be with an excimer laser, or the other one is a multifocal lens that has different areas of focus based on both the pupil size and how the lens sits on the eye. And that strategy can provide good distance and near acuity, but has some downsides having to do with pupil size and changes biologically that happen with that, and also with the contact lens, which can move on the eye, also causing some issues. So again, imperfect strategies that might work in some, but certainly not in all and not in most. Those are two different strategies. Now, the principle that has some really significant traction is the pinhole principle. And this goes all the way back to the 1700s, where there was a description by an optical physicist who was at the time a real Renaissance man, or probably pre-Renaissance. And he described the Shiner principle. And this really is a circular pupil, small, that prevents peripheral light, but also focuses central light and provides something called an increased depth of focus. And an increased depth of focus is what happens in that eyeball when you have a small aperture, which is a small opening or a small pupil. Now, pupils can be done artificially. That was the camera inlay I described prior. That's a piece of plastic that has a small aperture in the cornea. Now that's
a
not
surgical procedure.
That's a surgical procedure. That's right. And then there are now as actual implants. In Europe, there's an implant that you can use in patients who still have their natural lens. That's called a phakic implant. And in the US, there's the recently approved Apthera, which is an implant for what we call an intraocular lens, which also uses a small aperture, a 1.36 millimeter aperture, making a small pupil in the eye itself. But to me, and again, this is something that I've studied, and so has my team. The more interesting of all of these is physiologic miosis. And by that, I mean constricting a pupil using the natural pupil, which is the iris. And that is really a pharmacologic option. And that's where we kind of took the story up with the three folks I mentioned, Jim McCullum, Lee Nordan, and Jerry Horn, who were sitting there scratching their heads, thought about all these things and said, what if we could constrict the human pupil and really get that down to a size that allowed an increased depth of focus? Now, we talked about accommodation, and accommodation I mentioned is measured in diopters. And so when Jerry and Lee were discussing this with Jim, they sought a very specific dioptric equivalent. They were looking for a 2.5 or so, 2 to 2.5 diopter reading at. And that meant that they now had the basis for how small the pupil should be. So they said, look, there is a principle. It's called the Rayleigh limit. A lot of physics, a lot of math, but important to understand that once you got below 2 millimeters, you developed a very, very significant improvement in your ability to focus. That's normal English way of looking at it. And you can say it a lot of different ways. You can say it that they had an increased depth of focus or their depth of field. I mean, dozens of ways to say it. But the truth of the matter is, the simple way is once you got below 2 millimeters, you were really able to get a significant improvement in that accommodation dioptric add portion.
Is that why the Chimera was they designed it at 1.6?
That's correct.
And that is correct. They
is at 1.36. That's right.
They wanted to get below 2.
They wanted to get below 2, and
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
what's unique about these, and the morsure also, which is used in Europe, is below 2, a phakic implant. What's interesting is when you just move away from all the commercial side of this and look at just the science, there's almost unanimity in what the ideal pupil is. It's somewhere between 1.5 and 2 for the most part. And that's at the pupil plane. That's where it does matter a little bit where this occurs in the optical system, but it's pretty clear if you wanted to get really good depth of focus and make sure that you didn't have a big impact on distance vision, and that's something we haven't even talked about. You have to be really cognizant, aware of the Raleigh limit and what that means. Now, that really pushes the story towards which drug, what's the drug that you want to use? So if I told you, okay, I've looked at the physics, and the physics, by the way, is validated by the peer review literature that looks at different aperture sizes in humans. And when that was looked at, and that was done by both Sharman and Whitefoot and Campbell, these 3 folks spent really huge amounts of time with different apertures in front of human eyes and said, which one of these gives the best depth of focus? And they all showed the same curve, effectively looking at sub 2 millimeter pupils is kind of that ideal area. But then you start to look at which drugs work. And there are really 3 that were in common use. And when I say common use, it doesn't necessarily mean they were in the US. The first 2 that were in the US were pilocarpine and carbachol. And those 2 drugs are very strong pupil constrictors, but they also have a significant effect on the ciliary muscle. Now, you might think that's good because I've talked about the ciliary, and that does affect the zonules and the lens. But the problem is if you have an inelastic lens, which by definition at age 45 to 50, your lens is no longer plastic. It's not like silly putty where it changes shape. It's kind of a rock hard structure like a marble. Making it change shape will cause a forward motion of the lens. And that means the lens doesn't just change shape the way a 20-year-old lens, it pushes forward. And the effect of pushing forward is that you're going to induce some nearsightedness or myopia. And so if you're a pilocarpine or a carbachol drug and you try to get a pupil below 2, you make that eye nearsighted, which means that it's not ideal, because then these poor patients use the drop and now they need new distance glasses because they're now a diopter or so more nearsighted, in addition to whatever issues they still have with near. So it's not an ideal drug. And so both Jerry and Lee kind of wrote off pilocarpine and carbachol because they both share this effect on the ciliary. And what they really were intrigued by was this old drug that had been used in Europe for a very long time and didn't come to the US because it didn't work very well on the ciliary muscle, if at all. And so it was a ciliary sparing drug and a pupil selective drug. And that turns out to be quite good. In fact, in 1972, a doctor at Wills, Dr. Stephen Drance, wrote a really lovely paper comparing both pilocarpine and carbachol to aceclidine, and came to the correct conclusion that it wasn't a great glaucoma drug because it didn't really open the trabecular meshwork, which glaucoma drugs need to do, because the aceclidine had a real minimal, if any, effect on the ciliary muscle. So fast forward to Jerry and Lee, and they say, aha, here's an interesting drug. And the drug is aceclidine. As I mentioned, it's well known in Europe. It's been used commercially for over 40 years. We've certainly spent a fair amount of time understanding its use in Europe at higher concentrations and more frequent dosage. So there's an extensive experience in Europe with this drug for patients who couldn't tolerate carbachol or pilocarpine early in the glaucoma story in the 70s. The third choice was aceclidine. And in rare cases, it was still used in Europe. So we get into the US and it's now a new chemical entity. And a new chemical entity in the US, to bring that through FDA, is not a small task, and which we're very much in favor of, because we want the drug to be understood and examined, so that if there are side effects, we know them, and that the consumers, the patients, and the prescribers have a really good understanding of the drug. So that's what we've done, is we've spent really the past 5 years in clinical trials, making sure that we understand this drug, that it's the right formulation, and that we get these pupils between 1.5 and 2 millimeters for a long period of time, because I think most people want to use this once a day and get a good bang for your buck, if you will. You'll get a good near vision.
I mean, I think it's great because it's pupil selective, and you don't induce myopia, so you're not getting accommodation. And when they did the trials, the onset was very fast. Was about 30 minutes, and it would last.
Yeah, well, and actually slightly more. You know, we measured at 30 minutes, and I think you've seen the data. The data is very consistent at 30 minutes, all the way out, to 3 hours. It's in the 70s, 3-line gain with no more than 1 line loss. That's the FDA metric. But the clinical metric, what I care as a clinician and you care as a clinician, is, can the patients go outside, get the drop, and look at their iPhones, and 15 minutes later, these patients are able to read their iPhones, and that's typically a 2-line gain. So, whether they're sitting in your office and you put the drop in, and 15 minutes later, they've got really 90 to 95% at half an hour are seeing that 2-line gain. And it comes on very quick. That's the real nice part about the drug.
And any problem with LASIK patients or pseudofakes?
Not that we've seen, but we're still deep in data. Our top line data didn't segregate out the LASIK or PRK or pseudofakes. We did not use multifocal pseudofakes. We didn't allow those in. These are monofocal pseudofakes, and again, the inclusion criteria were very clear: -4 to +1, with up to 2 diopters of astigmatism. So that's a huge part of that 128 million patients between the ages of 45 and 75. Our mean age was 55, so we have a really nice distribution across this, and it's really a broad range of patients that you can treat with this. But again, data is still being analyzed.
With some of the other medications, with the pile of medications, carbachol could affect distance vision. But what happens with distance vision with aceclidine?
So the aceclidine really, in our trial, as a mean, and again, this is not any individual patient, but as the group as a whole, when you look at them, there are small but statistically significant gains. Small meaning 2 to 4 letters of gain. Now, remember, these patients had to have a minimum distance acuity of 20/25 to enter. So there wasn't much they could gain. And in fact, most of them were close to 20/20 or better. But the fact of the matter is, we had statistically significant improvements in distance acuity. And people have a hard time understanding that, but we're very serious about, there is a pupil sweet spot for this. And that's that 1.5 to 2. 1.5 to 2 millimeters really provides a very good broad depth of focus without the detriment to the distance acuity in most patients. And that's what our data showed, is that pupil size, and you picked up on it immediately. The F-thera is 1.36. We're all aiming at this same narrow area, because the physics and the optics all point to this being the best place for the pupil to be for our activities of daily living, both distance and near.
And how about aceclidine and dim when the vision's getting like dusk or dusk?
So, again, we're top line data, and there were some reports of dim vision, no question. It was reported as mild by everyone, 100%. So the dimming it was reported as mild when it did occur, and it wasn't in a huge number. But do remember that these patients always would have the option of discontinuing, and not a lot of them did. We watched patients for 6 weeks, and we watched patients also in our safety study for 6 months, and the dimming was described as mild. I can tell you that it partially may be due, and again, this will be a data-based, but my theory, and again, theory, is that when you have a miotic, a pupil constrictor that works in 15 minutes and takes you from 5 to 2 or less than 2, 1.5, you're going to notice that there's a reduction in the illumination. It doesn't seem to bother people very much because they are seeing things much more clearly, and that may provide an additional benefit. But yes, there are people who do notice that it's a little dimmer. Also, over time, there's neuroadaptation, which has been reported in other studies. So I expect that these patients get very used to this drop and say, oh, I'd much rather see well at all distances than I would worry about a small amount of less light. That's what we're seeing.
And because it's sphincter, pretty much sphincter only, do we have to worry about retinal detachment?
Well, again, this class of drugs, all the miotics are something that you should look at. I'm going to suggest that every patient is going to need to have a good dilated exam sometime around the time and make sure. But again, not that we've seen and not that's been seen in the European literature. We were very careful to go back and examine the markets where this drug was approved and could not find retinal tears or retinal holes based on this use of drug, which was used much more frequently. It was up to 4 times a day at much higher doses, meaning 2% and 4%. And they didn't report this. With the current trial, we, as I said, we are watching very carefully. We have finished our trial. So there's no data at this point that suggests that LENZ, that the Aceclidine alone has a propensity for retinal tears or holes.
Before I get into the Clarity trial, I do want to ask you about headaches. That's pretty common with pilocarpine. With Aceclidine, is it less, significantly less?
Well, again, we didn't do a comparative trial, so I hesitate to use the word less. We did have patients with headaches. The 89% of them were described as mild. There were some that were moderate, described during our trial. And it wasn't a huge number in terms of overall, but somewhere in the 6% when you corrected for placebo. Remember, we ran this trial against a placebo in our long-term study, and 3.9% of them described headache with the drop. So when you take away the 3.9%, where obviously they're getting a headache from life, not necessarily a drop, because there's no miotic effect on the vehicle, which is what it was. You see that it's a pretty low rate, but it's still there. And I'm sure in some patients they may say, I'm not going to take this, it caused a headache, but it was not a large number, and it was for the most part mild. And again, over time, when we analyze our data, I think we should be able to answer, does this headache get better with time? Which interestingly, with pilocarpine, we certainly have seen that happens. I expect it will happen with this drug.
I mean, I was around when we used to use pilocarpine for glaucoma, so I'm very familiar with pilocarpine. Now, when
you and me both, because I started off with intracap surgery. We didn't do phaco, we didn't have extra caps, and I was taking the iris off the anterior lens capsule in every one of those glaucoma patients because of the posterior synechia, which drove me nuts. I mean, I just remember my first years in practice, it was like every other patient had a bound down pupil that I had to remove. And again, that's another reason why I'm not keen on the pilocarpine. And I think a lot of practitioners who remember those days say carbachol and pilocarpine and they want to walk away. Those things are not reported with aceclidine. That's one of the things I looked in the European literature for. And that really validates the ciliary sparing component of this drug. It really doesn't push the anterior lens capsule of the hardened lens into the posterior iris. So that's another kind of quiet little benefit that I think clinicians will see over time with the use of this drug.
So, and Clarity too, it did show that there was some improvement in about 2 to 4 letters with distance vision.
That's correct.
And I mean, I think that's something that's pretty impressive, and that there was no real negative impact in low illumination.
Right.
And, and that 75% of the people would continue after the study was done. Can you talk a little bit about that?
Yeah, so, we have our patient-reported outcomes, and we have a slide that goes through 3 important ones. And you picked up on an important one, that 3 out of 4 patients are saying they would use this if it were commercially available. Now we didn't discuss anything really about that availability. It's just a simple open-ended question. If this were available, would you use it? And I think the fact that 3 out of 4 folks who took this and used this drug felt pretty strongly they would want to use it. And I think you also see that I think it's 81%, and correct me if I'm wrong, I'm doing it by memory, but 81% would use it 4 to 7 days a week. And to me, that's kind of the real draw here, is that most of these patients were very happy with their drug and they liked using it. And that was something that I think came across in these patient-reported outcomes. We're getting much more data through the analyses of all the patient-reported outcomes. These were just 3 of the questions that were asked, but we're going to get a real good idea and understanding of how these patients viewed this drug and what it meant for them as a daily solution to the I can't read problem, but I also want to be able to drive my car. I mean, to me, you picked up on really the critical factor here is whether they're wearing glasses, contact lenses, whatever their distance vision need. If you can go ahead and give them a drop and make that distance vision not worse and possibly a little better, but more importantly, provide them with now the ability to see their dashboard and see their handheld device, that's a really big step forward. And I think that's what this drug really represents. And by the way, all day long. I mean, wow.
Right. It's once a day, no preservatives, right?
Right.
It lasts 10 hours, maybe more. Starts within 15 minutes to a half hour. I mean, so no myopic shift, no significant myopic shift. I mean, I think this is just fantastic. As they come out with different companies come out with medication to help our presbyopic patients, there's always the first on the list. And now as new medications come out, this is going to be a new medication to the US. There's always improvements when new things come out, as we know from whether we started with the cell phone or computer or medications. From when I started treating glaucoma, when there was propine and pilocarpine, and now we don't use either one of those medications.
Exactly.
So things are always getting better. And I really applaud you and LENZ Therapeutics for really doing the heavy lifting on this and looking to bring this to the doctors like myself, who are going to bring it to the public, who many of them are listening to this podcast, because tens of thousands are going to be listening to this. So I really want to thank you and your team for coming up with and doing the hard work on this. Is there anything that I left out that you'd like to share before we end the podcast?
No, I think you've asked great questions. I really don't have anything more to add to this story. It's a good story. I think you have said, I think the critical part, which is we really want to be thorough. We want the practitioners to know what this drug does and doesn't do, and have a really good sense of how this works at a molecular level, which I think we have a pretty good understanding of, and how this works at the patient level, and who is the best patient to put this in. And we're working very hard to get this so that we can submit to the FDA and get this approved, and the package insert and the prescribing information we want to make as accurate and as educational as possible, and answer the questions that we can, and recognize we don't have all the answers. No one does. But we will do everything we can to parse this data in a way that provides who this patient population is that would most benefit from this drug. I alluded to the fact that in the US there are 128 million, and I think we will help a substantial part of that. But again, the goal is for us to really make this drug understood by those who prescribe it and those who want to use it. And I think we're on the way. There's no question. But you're right, it's a heavy lift.
Well, I want to thank Marc Odrich for joining me today, and I want to congratulate him for the great work he's doing. And until next time, this is Dr. Kerry Gelb for the Open Your Eyes podcast. Thank you.
Thank you, Kerry.
Hold on one second.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.